Good morning, or good afternoon, depending on where everybody is. This is Luke Evnen. I'm the chairman of the board of the Scleroderma Research Foundation, and I'm also a scleroderma patient. We truly are spanning the globe today. I'm here moderating from Boston. Our speaker generously has made himself available from London, where he's based, and of course the SRF staff is hard at work in the home office in San Francisco. This is our 14th live webinar, and I'd like to just remind everybody that our entire series, as well as a variety of other patient and research-related news, is available at no cost at our website, sclerodermaresearch.org. Also, as I've reminded you in the past, the SRF depends exclusively on your support to speed progress toward better treatments and a cure. So please consider making a donation after our time together today. And also, as an additional incentive, through the end of May, your gift will be matched dollar for dollar as part of our Spring Research Challenge. Our webinar series is made possible through generous grants from Gilead Sciences, MedImmune, Shire, and United Therapeutics. Today's session will feature 40 minutes on scleroderma complications in the kidney. We'll then wrap up with about 15 minutes of questions and answers. The phone lines have all been muted for now, so if you have a question, please use the chat box in the conference window. And at the end, I will try to work through those questions and aggregate similar ones so we can get through as much of the queries as is possible. Remember, our webinars are for educational purposes only, and no information provided is to be considered personalized medical advice. It's now my distinct pleasure to introduce our special guest. Dr. Christopher Denton is Professor of Experimental Rheumatology at UCL Medical School and the Joint Director of the Centre for Rheumatology at the Royal Free Hospital in London. He runs the largest scleroderma service in the UK with more than 1,000 scleroderma patients, and Chris has published extensively on the laboratory and clinical aspects of Raynaud's phenomena, connective tissue disease, and pulmonary hypertension, as well as, of course, kidney disease in scleroderma. Chris is acknowledged as perhaps the leading world expert on today's topic, scleroderma in the kidney. It's now my pleasure to introduce Dr. Christopher Denton.
So, Luke, thank you very much for that kind introduction. I really am impressed by the fact that I can be here in the evening in London after my clinic, giving you a seminar that's going internationally, and I hope that we can have a good discussion. So, I'm honored to be doing the 14th webinar. I think in a way I'm following on from the 13th, which focused a little bit on organ-based complications of scleroderma, but I want to particularly focus on the kidney in scleroderma, or more particularly scleroderma in the kidney. So what I'm going to do over the next 35 minutes or so is to consider a little bit what an important organ the kidney is and how it is affected in scleroderma and systemic sclerosis. I do want to make the point that we're not just talking about scleroderma renal crisis, but in fact that is of course the most important renal complication, and we will be discussing that in quite a lot of detail. And one of the things that I wanted to do during this webinar, which I hope isn't going to challenge the technology, is to share with you some of our patient experiences of renal crisis and really introduce you to one of our patients who's a survivor of renal crisis, but I think also illustrates the challenge that this complication presents. I'm going to finish up just by a brief thought about some of the future research that's ongoing and the ways that we hope to improve things further. So the kidney is a remarkable organ. We're blessed to have two kidneys. Like a lot of vital organs, there is a a considerable reserve, and in fact, all of us, when we're young and healthy, have roughly 4 times as much kidney function as we will need for the whole of our life. So normally, kidney function is more than adequate, and it's only when you get a substantial reduction in kidney function that this starts to be clinically very significant. But milder degrees of renal impairment can be relevant, particularly when you consider the impact of a disease like scleroderma. So the kidney is, as you might expect, quite a complex organ when you look at the structure of it, and here is a section, a histological section of a normal kidney, and what you can see is that clearly blood supply is very important. You've got an artery here and a vein here, really representing the importance of the blood supply to the kidney, because it's a very metabolic organ. It needs a lot of blood supply, but also because its critical function as a filter depends on having a blood supply to this structure, which is called the glomerulus. So the glomerulus is the filtration unit of the kidney, and probably the most important function that the kidney normally regulates is filtration of the blood. And it's not just a trivial amount of filtration. In fact, 1/4 of the cardiac output goes to the heart each minute, and the kidney produces urine from this filtered blood. It produces about 1 liter in an average adult, but this 1 liter is actually a concentrate from more than 1,000 liters of filtered blood. So you can see that the kidney is really quite a remarkable organ. You have blood coming into the glomerulus, you have it being filtered, and then the structure of the kidney is a very complex regulator of acid, salt, water balance. And this is critically important because rather than being just a simple filter, the kidney is an organ that regulates a number of vital functions. So, as you might expect, through its effect on salt and water balance, it's an important regulator of blood pressure. The simple filtration role gives it an important role in eliminating waste products, and when your kidneys fail, this is one of the reasons why this is a potentially lethal complication. But it's also an important organ producing a number of hormones that regulate blood formation and bone marrow function, hormones that regulate salt and water balance, and it's an important activator of vitamin D, which is critical for bone formation and calcium balance. So you can see that when your kidneys fail, you don't just lose something that's important for waste removal, you lose a lot of other potentially critical functions. So I wanted to really introduce the kidney as really a fascinating organ that really deserves consideration in its own right. But it's also an organ that can be affected by almost all the different forms of scleroderma, and in particular systemic sclerosis. And as you will be aware, systemic sclerosis is a variable condition that has different clinical patterns, but certainly patients with limited systemic sclerosis, diffuse systemic sclerosis, and in particular with overlap scleroderma, where they have also features of other rheumatic diseases, the kidney can be very, very important. And it's important not just because it can be involved in the disease, but also because it plays a vital role in regulating the excretion of some of the drugs that we use to treat scleroderma. So although any of the subtypes of scleroderma can affect the kidney effects in scleroderma, particularly the severe ones like the scleroderma renal crisis shown in this biopsy, is fortunately a complication that only occurs in a minority of patients. You'll see in a minute that it can affect around 14 or 15% of patients with diffuse scleroderma, but clearly in the majority of patients, scleroderma renal crisis does not occur. This is different, of course, from other complications like secondary Raynaud's or the GI manifestations that affect everyone, and perhaps more in line with what we see in lung fibrosis, in pulmonary hypertension, in cardiac disease, where it's a major problem for a minority of patients, but when it does occur, as we will hear in a minute, it can be a devastating clinical event. So as Luke said in his introduction, we look after a large number of scleroderma patients in our centre in London. We're currently following around 1,200 patients with scleroderma, and one of the benefits of looking after such a large number of patients is that we can really start to understand the timing and frequency of the different complications that occur. And I've put this figure up, which is taken from one of our very recent publications, just published online, but it is an important figure because it represents the current frequency of the major complications of the disease that we see essentially in a consecutive series of around 700 patients, all followed for at least 10 years, attending our centre, and all closely observed, closely followed. So what you can see is that here's the kidney involvement shown in purple, and it's quite clear that patients with diffuse pattern scleroderma are much more at risk of scleroderma renal crisis. Around 14% of patients develop this. You can see that almost always it develops within the first 2 or 3 years of the disease. And this is different from some of the other complications like lung fibrosis, like pulmonary hypertension, which can develop and become severe throughout the course of the illness. A similar pattern is seen in limited disease, but with a much lower frequency. Only about 3% of our patients with limited scleroderma develop a renal crisis. So that's the most severe and most dramatic renal complication. But if we're thinking about scleroderma in the kidney in a more general context, it's important to remember that many patients have a much milder involvement of the kidney from their disease. This is important because it may not be clinically significant as an independent problem, but it can certainly impact upon the stresses that scleroderma causes when you have other problems, when you have high blood pressure, when you have infections, and of course, as I've said, when you're on complex medication that may be excreted through the kidney. So a few years ago now, we again used our opportunity of just following a large number of scleroderma patients just to try and assess what the background level of kidney abnormality was. And we were struck by the fact that when we looked at essentially more than 100 patients, just consecutive cases coming through the clinic who agreed to take part in the study, that we found that in fact 2/3 of these patients had significant impairment of the kidney function. This is classified as what's called chronic kidney disease stage 2. But what that means is that you've got that the filtration function of the kidney has dropped below what is normally considered to be a normal level for a healthy adult. So that's the first thing a point I'd like to make, that although scleroderma renal crisis occurs perhaps in 15% of diffuse scleroderma patients, kidney involvement is much more common than that. More importantly, it's not just the filtration function that is abnormal, but also the actual functioning of the functional units of the kidney, because when we looked at microscopic proteinuria, this is just looking for traces of protein in the urine that have either come from the glomerulus because it's become too leaky, or from the tubule because it's failing to absorb and regulate proteins in the right way. We saw that just under half of the patients had evidence of microscopic proteinuria. This is not the sort of protein you can detect when you do a regular stick test of your urine when you go to the doctor's office. This is a much more subtle abnormality, but it does tell us that there are clearly significant abnormalities occurring in around half of patients with scleroderma. So with that in mind, I'd just like to consider for a while how we think and how we understand how this background, more minor problem in the kidney can develop into such a life-threatening emergency of scleroderma renal crisis. And I'm going to take you through this histologically. I'm going to take you through this by showing you sections from kidneys that we've taken from patients who haven't had renal crisis, where we've had tissue samples obtained in other ways, and from patients who've had renal crisis. And so here are some sections that show the kidney of a patient with scleroderma, but who hasn't had a scleroderma renal crisis. And I think what we're seeing here is the correlation of that background kidney dysfunction, the fact that 2/3 of patients have reduced kidney filtration and half patients show evidence of abnormal glomerular function. And this is due to fibrosis, a background level of fibrosis in the kidney, due to inflammation. Here you can see immune cells, lymphocytes within the kidney. And here, very interestingly, you can see even in a patient who hasn't had a scleroderma renal crisis, blood vessel abnormalities that will look quite similar to the changes I'm going to show you in a minute that occur in a renal crisis. So we think that what happens to change this relatively stable, indolent abnormality in kidney function into a much more severe problem is that something occurs to injure or damage the blood vessel. And here you can see a blood vessel from a kidney that's undergoing a scleroderma renal crisis. And what you can see is there's damage to the lining cells of the blood vessel, and there's evidence of damage to the cell wall. So the damaged blood vessel produces a whole range of factors that would normally be good factors helping for tissue repair, but they're produced in excess and persistently. So the result of these is that you start to get this proliferative overgrowth of the lining cells of the blood vessel in the vessel wall. You start to get damage to the blood vessels that's even more intense and start to block the blood vessels. And because of this lining cell layer damage, you get thrombosis. So all of these three events have the end result of really starving that important functional filter unit, the glomerulus, of its blood supply. And you can see this is a glomerulus of a patient having a renal crisis. It's all shrunken because it's not getting enough blood. And as a response to this, what the kidney tries to do is shut down the blood supply to those damaged glomeruli, hoping that more healthy areas of the kidney can take over. But unfortunately, because of these other events that are going on in the scleroderma kidney, what happens, in fact, is that the very mechanisms that are enlisted by the body to try and compensate for this poor blood supply to the kidney glomerulus actually lead to changes that accelerate the damage to the blood vessels. And so now you can see why when a scleroderma renal crisis starts, it's a little bit like lighting the fuse to a fire and then adding accelerant. The fire takes off, and it's almost impossible without the right tools to interrupt that. So that's the laboratory side, if you like, the biology of scleroderma renal crisis as we understand it and as it develops. But what I'd like to move on to now is the clinical challenge of the scleroderma renal crisis, what we as physicians looking after scleroderma patients see when a patient presents with a scleroderma renal crisis. And what I'm going to do is to first of all go through the medical aspects of it, and then I'm going to share with you our patient experience of what it was like to actually go through these events. So, as you might expect, when the blood supply is cut off to that functional unit in the kidney and when the blood pressure rises, one of the key features we see in a scleroderma renal crisis is a rapid progression of renal failure. The kidneys just stop working and the blood tests reflect that. And this can develop over a matter of hours and certainly over a matter of 1 or 2 days. At the same time, the blood pressure goes up because of the mechanisms I've said and because the kidney is so critical at controlling blood pressure. This causes major problems. Because scleroderma patients already have damaged blood vessels, those blood vessels are particularly prone to the effects of high blood pressure, and so they start to leak. They cause headaches. You get leakage in the back of the eye, which is shown here, and this causes visual problems. It causes a process called encephalopathy, which is when the blood vessels leak in the brain. This causes seizure activity, and it can cause major problems with consciousness and with cognitive function. In the lungs, the leaky blood vessels respond to this high blood pressure by filling the lungs with water and stopping patients breathing and getting oxygen. So you can see that it's a catastrophically severe medical emergency, and certainly once a renal crisis is established, this is not a clinical event that is going to be missed by physicians. The challenge, of course, is to try and detect and diagnose and start treatment before it reaches this very severe end stage. I will talk in a few minutes about some of the advances that have occurred into treatment of renal crisis, but I just want to emphasize right at the beginning that treatment of scleroderma renal crisis probably represents the biggest treatment advance for scleroderma overall that has occurred in the last 30 years, really, because what you will see is that scleroderma renal crisis, from being an almost inevitably fatal complication of the disease, has become one where we will normally expect patients, once the diagnosis is made, to at least survive the renal crisis and hopefully do much better in the longer term. Just to give some figures to that, and I'll come back to that in a few slides' time, once drugs called ACE inhibitors, so fairly routine drugs now used for heart failure and high blood pressure, once they were introduced into patients with scleroderma renal crisis, they absolutely transformed survival. You can see that prior to the late 1970s, the one-year survival from a renal crisis was well under 15%, and it was the commonest cause of scleroderma-related death. After routine use of ACE inhibitors, the survival now is well over 70%, and in fact higher than that now with modern treatment. So because we have a large cohort of scleroderma patients that we're looking after at the Royal Free, we have a large experience of managing scleroderma renal crisis, and this is important because it is a complication that requires expertise to secure good outcomes. We treat roughly 10 to 12 scleroderma renal crisis patients a year. That may not sound like many, but it's a big clinical challenge, and certainly more than any other center sees, certainly in the United Kingdom. Because of this, we've built up a large experience, and we've been really trying to use this experience to understand which patients are most at risk, what are the factors that help us to try and predict a renal crisis. We published our series of 110 patients with scleroderma renal crisis about 7 years ago now, and this was at the time the largest series of scleroderma renal crisis, and again gave us very important and useful information. We're just finalizing our next review of renal crisis, where we've now got up to 150 patients with renal crisis. The messages are quite similar, though. The demographics, the age and gender of patients that get renal crisis are, as you'd expect in scleroderma, about 80% female. It's not a complication that specifically picks out male or female patients. A very important observation that we may have made is that about 1/5 of patients who present with a renal crisis have this as the presenting feature of their scleroderma. And this is very important because, of course, until you've been diagnosed with scleroderma, no one is going to be thinking about scleroderma renal crisis as a clinical complication. So it's a particular challenge to try and make sure those patients get the best treatment as promptly as possible. As I showed you earlier, from our more recent series, 2/3 of renal crisis occurs within 1 year of onset of the scleroderma. So it is a complication of early scleroderma, and it is much more common in diffuse scleroderma, as I've said before. But perhaps the most important clinical message we got from this study was the very strong association of scleroderma renal crisis with a particular blood test in scleroderma, and this is the anti-RNA polymerase autoantibody. I'll come back to that later, but I think that identifying patients with this antibody is very important because patients who have this antibody are more than 10 times more likely to have a scleroderma renal crisis than others. The other thing that we confirmed was the observation of Virginia Steen and others in the United States that steroids are associated with the development of renal crisis, and more than half of the patients that we saw had received significant doses of corticosteroids in the 1 month before their renal crisis. And this is even in an era where we're trying to minimize steroid exposure because we know of the risk. So it's still a real issue. But that's the medical perspective of scleroderma renal crisis, and what I want to do is to present also the patient perspective, and what I want to do as well is to transport you back in time, in fact more than 20 years, and we're going to talk to the first renal crisis patients that I was involved in managing in March 1991. I had just arrived from my internal medicine training as a rheumatology fellow at the Royal Free. I was working for Professor Black, who headed the unit at that time, and we were called, while I was doing my clinic, I was called about a sick scleroderma patient that had been admitted to the emergency room of a local general hospital. So we're going to hear Kim's story, and the first thing I wanted to ask her was really what she remembered about the events that led up to the scleroderma renal crisis. So, technology permitting, we will now hear Kim's answer. So, in response to the question, what do you remember about the scleroderma renal crisis, how did that start? This is what Kim said.
When I had the renal crisis, I didn't even know what renal meant. I had been going to the Brompton for some lung function tests. I got caught in the snow on the way home from the Brompton, turfed out of a taxi, so it took quite a long time to get home, so I had got very cold. At the same time, I was on an experimental drug, and nobody really knows what caused the renal crisis. But when I got home, I had a headache, and I never really woke up properly. I went into a coma that evening.
So, just as I explained, but really I think much more graphically, you can see what a devastating clinical event this was. Someone who was essentially reasonably well and alert, going from that situation to being in a coma and admitted to their local emergency room. So Kim was admitted, taken by ambulance to the local emergency room, and the next question that I asked her was really what she remembered about being in that emergency room and what it was like to be a scleroderma patient at that time. And I should say that what we're seeing is the way medicine was more than 20 years ago, and I would like to just make it clear that I think we've made some advances in a number of ways, but I think it gives you a feeling for how things were for Kim at the time.
Only what I've been told, and it was in the days when they didn't have any beds, so I was on a bed in a corridor. My mum was told where I was, and she walked straight past me because she didn't recognise me, because I think I must have looked strange, and I think if you've got renal failure you maybe look a bit puffy or something, I don't know. Anyway, she phoned the Royal Free, the nurse specialist answered the phone, thank goodness, and you were actually in clinic at the time, and I think she arranged, or you got her to arrange for me to be transferred.
So Kim was transferred to our unit, and again, looking at things first of all from a medical perspective, I just want to take you through, from a medical viewpoint, how we look after patients with a scleroderma renal crisis. Firstly, I think it is important that this is done in very close collaboration between your scleroderma specialist and the renal physicians, renal specialists in the hospital, and we've got a very close working relationship to look after patients. The first thing, as I've said, about managing a scleroderma renal crisis is that you need to be able to suspect the diagnosis. You need to have a confirmed diagnosis of scleroderma. The patient will often develop high blood pressure as an early feature, and this is a warning sign, and so we always try and educate our patients to regularly measure their blood pressure to get an idea of what their baseline blood pressure is, so that they can contact us or their physician, their family doctor, if the blood pressure is elevated. We will carefully watch blood pressure, and it's if the blood pressure goes up in systemic sclerosis that you really need to be started on one of these drugs, ACE inhibitors, to try and control that. Things become much more serious if, when we do blood tests, we start to see evidence of damage to the blood cells in the blood, fragmentation of the blood cells, or if we see evidence of kidney impairment. So we can measure substances in the blood that are normally excreted by the kidney, and if those substances like creatinine start to rise, then we know that there's impending kidney damage, and this is really a very serious situation. The patient needs to be admitted to hospital. They may need to go to an intensive therapy unit. We would treat them with ACE inhibitors, with other drugs to lower the blood pressure. In our center, we routinely give a prostacyclin infusion, which we also think is helpful to the blood vessels and helps to control the blood pressure. Unfortunately, despite all of this, it's not uncommon for patients to progress to failure of the kidneys. So they're not excreting their fluid, electrolytes, or waste products to such an extent that they actually need to go on to renal replacement or dialysis. And so that's what often is needed. We're going to talk a little bit about the other options for transplant and about recovery in a minute. But first of all, I've shown you this schematic of what it's like to, from our point of view, but again, I want to hear from Kim, from her perspective, how her renal crisis was treated.
The first thing they had to do was put in a central line. I had hemodialysis, which is the blood, removing the blood, cleaning it and putting it back in again. And I didn't do very well on that, possibly because I've got scleroderma and my veins weren't working, don't work properly. So as soon as I changed to peritoneal dialysis, I did a lot better.
So Kim's kidneys unfortunately did fail completely, in fact, but as you'll hear in a minute, ultimately they recovered. This is a very important point in managing patients with scleroderma renal crisis, and this is why you need expert renal physicians who are familiar with the complication with this disease, because scleroderma renal crisis is one of the few situations where it can look like your kidneys have permanently failed, but in fact there is the capacity for some recovery. So here you can see figures taken from our review in 2007 of renal crisis looked after at our hospital. You can see that 2/3 of the patients that we look after, like Kim, did have to go on to hemodialysis or peritoneal dialysis. Only 1/3 didn't fail enough to need dialysis. But what you can see more positively is that half of the patients that did go on to dialysis with kidney failure eventually managed to come off dialysis, which is quite a remarkable situation for a kidney problem that causes such profound renal dysfunction. You can see, of course, though, that the average time to coming off was somewhere between 1 and 2 years. So this is not a quick turnaround. It really reflects a longer-term recovery. And here in the lower panel, you can see that although most of the recovery occurs in the first year, you regain about 1/6 of your kidney function on average after a renal crisis in the first year. You can see that you still have gains in renal function out to 4 years after your renal crisis. So this really does reflect a sort of remodeling or repair of the kidney from a very profound injury. However, it is very important that you do come off dialysis if possible, because the long-term outcome for a scleroderma patient who has a renal crisis who doesn't need long-term dialysis is much, much better than for those that require permanent dialysis. Interestingly, we don't see a long-term difference between those patients who didn't need any dialysis at all and those that just needed temporary dialysis. But what we do see is this very poor survival in patients who are on long-term dialysis. What I'd also just like to point out is that 1 year survival overall after a renal crisis is well over 80% now. So we've clearly made huge progress from those historic figures when scleroderma was such a high cause of mortality from the kidney involvement. So Kim was in the fortunate group. She was on dialysis for quite a long time, but things did improve substantially. And again, I think it's worthwhile just to share the experience that she had as things started to improve and as she started to be more positive about her condition, which had been really very, very desperate. So Kim will now tell us how things were as she started to recover.
Well, it was amazing. I mean, especially after the renal failure, I was very, very slow, and it took me a long while to come back from that. I mean, it took me probably 2 years before I could even read properly. And I remember sitting in Covent Garden one day, drinking a cup of coffee, and I burst into tears because I just thought I would never be able to do anything normal again, rather than just being sick all the time.
So I think that brings it home really the impact of how desperately ill you can be with a renal crisis, but there is capacity for recovery, and Kim has done, of course, very, very well from that. She also illustrates the problems that you have from the eye damage, from the brain damage associated with scleroderma, which again, you can make a good recovery from. So just to consider a little bit more about ACE inhibitors, these are not some magic treatment. They are quite an established drug now. They're used routinely for high blood pressure, for heart failure, but what they have done is they have transformed the survival long-term in scleroderma renal crisis. And interestingly, related drugs that are perhaps more specific in some ways, angiotensin receptor blockers, don't seem to be quite as effective as ACE inhibitors in the treatment of renal crisis. So you really need to use the standard old-fashioned treatment. And what we think this treatment does is it blocks that cycle of feed-forward worsening or acceleration of the high blood pressure that is a response to the injury that scleroderma causes to the kidney. So it really is transformative and in the short term really improves the outcome. What you might immediately think is if you've got a treatment that is so dramatically effective at treating renal crisis, perhaps we should put all scleroderma patients on this and try and prevent the problem altogether. And certainly in the past, this has been certainly a thought and practice for some units. There are now concerns about this, though, because a number of studies, including our own cohort study, a study in France, and most recently a multi-center study coordinated by the Canadian Scleroderma Research Group, have all shown that if you have a scleroderma renal crisis whilst you're on an ACE inhibitor, you actually have a worse outcome than if you hadn't been on an ACE inhibitor if you compared to the other patients. We don't understand why. It is, of course, possible that only very severe renal crisis breaks through ACE inhibition, or it may be, of course, that it is a factor that delays diagnosis, which is so important in scleroderma. But our current practice in our center is much more about trying to make the diagnosis as promptly as possible so that we can treat it rather than trying to prevent it, and certainly not using ACE inhibitors routinely. A word about kidney biopsy, quite an invasive technique, taking a sample from the kidney. I've already shown you biopsy samples taken from a number of our patients with scleroderma renal crisis. We think this is a very useful test to perform, particularly once the patient is in the recovery phase from the crisis, because we know that it helps us to understand the likelihood of the patient being on permanent dialysis or not, and gives us the earliest clues that we might be dealing with a situation where the patient will recover. Unfortunately, if the vascular injury is very severe, this points to a poor outcome. Patients are less likely to recover. But interestingly, the severity of that background fibrosis that I showed you on the earlier slide doesn't seem to relate to the outcome. So that is an interesting observation. The other thing that kidney biopsy tells you is that sometimes you have the wrong diagnosis. This is particularly important in patients who have overlap scleroderma, where patients may have features of lupus or other connective tissue disease, because you can develop the kidney complications of vasculitis or of lupus, as well as having scleroderma. So in our series of patients, we have 14 where we had clinically diagnosed a renal crisis, but when we did the biopsy, in fact, there was other renal pathology. We have one case here where she had a renal crisis. She then had worsening renal function a few years later. We biopsied her again, and she had a completely different pathology. She had membranous glomerulonephritis associated with an overlap with lupus. So biopsy is important, and it's certainly part of our routine treatment. But practical advice is probably more important, and I would just like to emphasize the role that our specialist nurses have in managing scleroderma renal disease, really from a preventative point of view, because we educate all our patients who are at risk of renal crisis of the need to monitor blood pressure and of the warning signs if they are starting to develop problems. We also, in our center, have a priority for educating family doctors and other relevant specialists so that they're aware of patients who might present even without a pre-existing diagnosis of scleroderma. And we give all of our patients with early diffuse scleroderma who are most at risk, we give them all a warning card to take with them and to carry with them and to show to doctors that may see them, giving them information about a renal crisis and some of the basic approaches that should be taken. One of the points about a warning card like this is it absolutely makes it essential that you have good patient education. You certainly can't give a card like this to a patient without explaining the significance and importance, and also putting this into context, reminding them that the majority of scleroderma patients, even with diffuse scleroderma, will not have a renal crisis, but it is a treatable complication if it occurs. So I just want to focus for one slide on kidney transplantation, because it is a treatment that can be very useful. And I've shown you that for that 1/3 of patients who have a renal crisis who go on to permanent dialysis, this can offer a real improvement in long-term outcome. Data, particularly from the UNOS registry in North America, show that the long-term survival for patients who have had a renal transplant is much, much higher, 80% 3-year survival compared to only around 55% if you're on the waiting list and unfortunately don't get a transplant. So I think that there's no doubt that transplantation should be considered, but only in patients when they're outside the window of recovery. And so certainly in our centre, we wouldn't ever consider this for 18 months after a renal crisis. And if it looked like a patient may come off dialysis, clearly that is a much better long-term outcome. Interestingly, we don't see high rates of recurrence of renal crisis after transplantation, but of course, as in any complex disease, transplantation is not without its hazards. So I'd just like to finish off the last few minutes by talking about some of the research that's going on in renal scleroderma, and in particular, some of the work that we're doing in our centre. And the points I wanted to make, first of all, is that I think as a scleroderma community internationally, we are working very closely together to learn from observed practice. This is a relatively uncommon complication, and therefore it does require group research to really understand the disease better, but we have a lot of collaboration, cohorts of renal crisis now in London, France, Australia, Pittsburgh, and of course the Canadian Consortium study. So this has been very important, I think, in defining risk factors and best practice for management, really. Scleroderma renal crisis is a very challenging area to do drug trials in, but we have risen to the challenge in our centre. We've completed one study in renal crisis, and we're about to start a second. And we're also working on better ways of predicting and assessing the renal crisis itself. So many of you will be aware that in other vascular complications of scleroderma like digital ulcer disease and pulmonary arterial hypertension, drugs called endothelin receptor blockers have been very effective. They're licensed therapies for pulmonary hypertension around the world, in the United Kingdom and in Europe. They're licensed for the treatment of digital ulcer disease in scleroderma based on robust clinical trials. But interestingly, in the kidney, in a renal crisis, you also see high levels of endothelin expression and endothelin receptor expression, as you can see in these histological slides. So based on this, we wondered whether adding an endothelin blocker in the recovery phase of a renal crisis would improve outcome, really recognizing the similarities between the changes that occur in the kidney in renal crisis and those that occur in the pulmonary artery, for example, in pulmonary hypertension. So we undertook BIRD-1, bosentan in renal disease. This was an academic study that we performed in our unit, treating patients by adding bosentan to their standard treatment. Now, renal crisis is rare. Over the 18-month period, we had around 10 patients that were eligible, and we enrolled 6 of these into this study. And what we were able to do is just, first of all, show that this was a safe approach to treatment. It doesn't seem that these drugs are dangerous in renal crisis. But interestingly, when we compared them to patients who'd been treated just before we ran this study, so using the same standard care but not bosentan, you can see that at all time points, 3, 6, and 12 months, there was a trend for greater recovery in those patients that received bosentan. So not in any way definitive evidence of efficacy, but I think somewhat encouraging. So encouraged by that, we have moved on now to embark on a second study of endothelium blockade in renal crisis. We've also used a zoological theme. This study is entitled Zebra, and there is Zebra 1 and Zebra 2 as sub-studies. So this is zibotentan, better renal outcomes in scleroderma. So we're going to do two studies. One is looking at the potential benefit of a selective endothelin antagonist in those patients that have this background kidney disease in scleroderma, to see whether we could perhaps reverse some of that using treatment with this endothelium blocker. And as a follow-on to BIRD, whether we could improve renal crisis outcome by adding zibotentan. So all the information about this trial is registered, as other trials are, on clinicaltrials.gov if any of you are interested. We've just received all of the regulatory and ethics approvals for the study, so we're about to start recruiting patients. And for anyone that's in the United Kingdom, we're encouraging patients to be referred to us who might be eligible for this study. So that's about treatment of renal crisis, but we would like to be able to be even better at predicting renal crisis, and I just think about two areas where we're working on. One is looking at blood markers for renal crisis, and the other is to look at genetic factors. So I've shown already that this antibody called the anti-RNA polymerase antibody, one of the specific scleroderma-associated antibodies that's really only seen in scleroderma, not in other autoimmune diseases, is strongly associated with scleroderma renal crisis, as we've seen. Interestingly, it's also associated with some other complications, pulmonary hypertension, watermelon stomach, and in an interesting study, and we've been collaborating with Johns Hopkins University in the United States, working on this, that there is an association in some patients between this antibody and in cancer associated with scleroderma, which is intriguing. But this antibody gives you about a 10 times increased risk of renal crisis. But what we'd like to have is a blood test that would maybe tell us when a patient with or without this antibody is actually about to have a crisis. And we have some encouraging data from some of the markers of vascular injury. Here, some data from quite an old study, but a study that shows that patients have high levels of this marker VCAM1 before they have a renal crisis. So we regularly sample our blood from our patients. You can see this patient had a renal crisis. The creatinine level went up as the kidneys failed, but actually 3 months before the renal crisis, this blood test was very highly abnormal. So we're going to be looking at that very closely in the ZEBRA study to see if we can predict better. So finally, scleroderma genetic studies are ongoing. Studies have really already helped to understand the autoimmune aspects of scleroderma, but we're now turning to try and understand the genetics of renal crisis, and we're doing this in a very specific way. We're looking, using the modern technologies, to look across all of the chromosomes for genetic abnormalities that might be associated with increased risk of renal crisis. But what we're specifically doing is seeing if there may be genetic factors that add to that risk that patients have who have anti-RNA polymerase antibody. So I've just completed our first genetic analysis comparing 100 patients with this anti-RNA polymerase antibody, but specifically comparing 50 of them who've had renal crisis with 50 who have the antibody but have been followed for at least 3 years and haven't developed a renal crisis. So we can suppose that these patients are protected from renal crisis in some way, and we think that that may be genetic. So we've done the study. We've identified at least 50 genes that are different. Some of them are quite significantly different, and some of them give a risk of up to 8 times higher of having a renal crisis. And this is already on top of that 10-fold increased risk from the antibody. So these patients may be up to 80 times more likely to have a renal crisis, and we may be able to understand much more about renal crisis when we identify these. We might eventually even have tests we can do to identify risk. So I want to finish there, but just to sum up really some of the clinical messages, scleroderma in the kidney is very important. It's most important because of the renal crisis complication. Outcomes are better than they used to be, but we still need to do better. We need to be very, very much aware of who is likely to get a renal crisis. We need to know that if we've managed a renal crisis, there can be renal recovery. We need to know that our patients should be referred for transplantation if they are on permanent dialysis, and that's possible. And we, as doctors, need to remember that not all scleroderma kidney disease is renal crisis, and always be mindful that there may be other pathologies. So my final remarks are just from Kim again, her perspective on having lived with scleroderma for more than 2 decades. and then I'll just make my acknowledgements.
Although being diagnosed with scleroderma can be a shock, especially when you look on the internet and you see quite a lot of negative stuff. But the good thing is to adapt. If you can learn to adapt and pace yourself, then, you know, life is for living. It's not for really worrying.
So I think with those words, I'd just like to thank Kim for sharing her experience, thank our patients and the patient organisations that we have in the UK, and of course the SRF for their support and for the for organising this series. And I'm very happy now to use some time to take questions.
Well, Chris, that was a really fantastic review, and very much appreciated. Thank you for a really comprehensive overview of kidney biology, and particularly kidney biology in scleroderma. Maybe I'll just kick off a little bit of the Q&A while some of the questions are just coming in. You sort of summarized it briefly, but I'm wondering if we can talk a little bit more about whether there's a specific window of vulnerability that we ought to think about as patients and as a community. It sounds like there's a temporal aspect to the vulnerability, that there's perhaps a drug-induced component to it, steroids rendering patients particularly vulnerable, and maybe some other drugs. I wondered if you might want to comment on that, and I have sort of a follow-up question to that as well.
Sure. So thank you. So there certainly is, and I think that's one of the messages we get from our patients, really, from that early diffuse scleroderma is clearly the high-risk time for a renal crisis. So that's the first thing to say. And if you haven't had a renal crisis, if you like, within the first 3 years of your disease, you are very unlikely to have one. So I think that's an important positive message. But there is a risk period. I would really like to emphasize the value of this antibody, the RNA polymerase antibody, because it's a commercially available test that really I think all scleroderma patients should have early in their illness, so that they can be identified as potentially at increased risk. So that's true. I think in regards to triggers, my feeling is that the scleroderma gives you the susceptibility, and then something triggers the crisis, and that could be many things, but I think it could be steroids, it can be other nephrotoxic drugs, and it's important to remember scleroderma patients do need steroids, sometimes they do need other drugs that can affect the kidney, so it's just very important, I think, to be aware.
Right, and then, you know, Kim was referencing a particular scenario, kind of reduction in body temperature, which, you know, can initiate a Raynaud's crisis, as we all know as patients. Obviously, you know, you have pretty strong blood pressure variation that's, you know, relatively correlated to time of day, as well as certain activities. Have you seen a correlation with any of those kind of maybe obvious environmental and diurnal variation type factors, Chris, that our patients might want to be particularly aware of? So
I think it is really, I mean, Kim gives a very clear history, perhaps one of the clearest that I've had of that episode of potentially cold-induced vasospasm. It's very plausible, I think, that you can get visceral vasospasm in response to cold, although clearly that's something that normally the body tries to avoid. So I think that may be relevant. We know it can occur in the heart, for example, and sometimes cause you know, coronary insufficiency. So it may be relevant. I think we also see, and this is again observational, that we know that renal crisis is certainly about twice as common in the winter in the United Kingdom than it is in the summer. So it's tempting to think that that might be relevant. But I think clearly more than that is needed to have a renal crisis, but it may be a cofactor.
Great. Let me try and sort of basket up a couple of these questions. And I think there's a little bit of confusion, Chris, and maybe you can help us sort this out, about sort of the RNA polymerase antibody test versus a quote-unquote ANA test. And maybe you can just help the patients understand sort of what's the difference and how do they go about making sure they actually get the specific anti-POL3 test.
Yeah. So thank you. So anti-RNA polymerase is a very specific autoantibody, but it is in fact just one of the anti-nuclear antibody reactivities that occurs in scleroderma. So all patients with an anti-RNA polymerase antibody will have a strongly positive anti-nuclear antibody, but it's the specific protein within the nucleus that is being recognized, that is the polymerase 3. So there are three main scleroderma antibodies: anti-scleroderma 70, anti-centromere antibody, and anti-RNA polymerase antibody. At least in our cohort, around 1/3 of patients have each of those antibodies. So it's one of the antibodies. Interestingly, in scleroderma, you will almost always only have one of these scleroderma-specific antibodies, and so it is important to have the test. But if you are already known to be positive for anti-centromere or anti-scleroderma 70 antibody, you really essentially won't have the anti-RNA polymerase antibody. So if patients really are concerned, that's the group of patients I think that would be, we would certainly recommend having the test. And it is a routine test, but it does have to be specifically requested, and it at least in the UK, and I'm sure in North America, it should be generally available through commercial labs.
Okay, just given the technical difficulties, I'm going to go over for another minute or two. I hope that's okay. We have a couple of other questions about maybe, is there something that the family of our scleroderma patients ought to know if their family member with scleroderma gets admitted to the hospital? In particular, is there a preferred method of kidney support? Have you found that hemodialysis versus peritoneal dialysis, if a patient ends up on dialysis, is better, or is there a particular regimen that seems to be more kidney sparing in the end? Do you have some recommendations about that, Chris?
Sure. So that's a very important question. Again, it's something that is clearly a complex medical issue. But as a simple rule, the least invasive form of kidney replacement is the best tolerated normally in a renal crisis. And so there are different technical forms, but hemodialysis or hemofiltration can be used, or peritoneal dialysis. In general, peritoneal dialysis is more gentle in terms of hemodynamics, and so certainly as a long-term option is often preferred if possible. But I think that unfortunately it's really a case of what you need medically at the time, balancing all the other medical issues. But certainly in the long term, as Kim said, her experience was that peritoneal dialysis was a much easier form of dialysis to live with, and she did very well on that, in fact, for several years, and is now off dialysis.
Yeah, that's a great story. Maybe just one final question, and then I'm just going to wrap up. It sounds like you don't recommend using ACE inhibitors on a preventive basis. My impression is that endothelium blockade, particularly Triclea or Bazantin, is used in a much more typically as a chronic care medication for scleroderma patients. Do you want to just comment on, if you will, sort of chronic medication and what patients might consider?
Yeah, so I think that the data from studies now, really from 4 different studies, all suggest that being on an ACE inhibitor is not advantageous if you have a renal crisis, and so we wouldn't recommend it as a preventative treatment. We're not really understanding why that is, but it seems that it's very effective once you have the crisis. Maybe it doesn't prevent it. Endothelium blockade is very attractive to think, especially as I showed you that high levels of endothelium occur at the time of a renal crisis. Whether endothelium blockade would be protective, it's attractive to speculate, but I think we don't know that. That's one of the reasons why we're doing the ZEBRA-1 study, in fact, with a different antagonist, but to see what the effect of endothelium blockade might be in patients who, if you like, are at risk of renal crisis but haven't had one.
Well, Chris, let me take just a minute and thank you once again. This has been really, really informative. I think patients are sort of uniformly found this to be very helpful and really right at the right level for them. So I just wanted to remind everyone that we're all part of the scleroderma community, and really only by joining together can we make faster progress in the search for better treatments and a cure. Dr. Denton has been not only a leading clinician, but a leading scientist in the field, and we've been honored to support his work at the Scleroderma Research Foundation, and look forward to collaborating with him in the years to come. So also, please remember that we depend on your support to continue our investment in the most promising research. Visit us online at sclerodermaresearch.org or call our offices at 1-800-441-CURE. Thanks again for sharing some time with us today. And remember that this webinar is available for free on our website. Goodbye for now, and thank you.